So that's separate from the data use agreement.
Yeah.
Okay. All right.
Yes, that's separate
So
from
the
a data
global use agreement is to share information between the agencies about the foster youth.
Right.
As I'm reading in the letter I received from the director yesterday, the data use agreement allows information about physicians who have prescribed multiple medications to foster kids. Okay.
So let me be very precise for you for a second. The one that I just described, the Global Data Sharing Agreement, is signed by Healthcare Services and Department of Social Services. And so that's the exchange between them. There's a separate data use agreement that's actually being signed, I believe, today. There were some signatures added to it between the Medical Board, Healthcare Services, and us to enable information to be shared with the Medical Board for the purpose of overseeing prescribing physicians.
Got it.
So that also, as I just said, is in the signature process. So there's two separate agreements there, but again, major milestones in our ability to share data and make use of it. And I should add that global data sharing agreement between our two departments also is available for counties that wish to access that information. At the same time, we understand County Council is working on a more narrowed agreement specific to the psychotropic medication topic, and we look forward to receiving that from them should counties not wish to sign on to the larger agreement. And I'm happy to take questions. I'm not sure I had anything else to add there.
Senator Monning.
Thank you, Madam Chair. Well, first I want to thank both departments for your work together and in focusing on this particular challenge, the use of psychotropic drugs. We had an extensive hearing, as you know, with the Committee on Social Services. We heard some compelling testimony from young people in the system and who'd come out of the system. And while there's judicial oversight in authorizing the prescription and administration of drugs, there seemed to be a shortcoming in equal access to counselors, psychiatrists, others to work with the youth. I'm talking about foster youth right now, to develop plans and strategies as opposed to a just kind of in perpetuity reliance on the psychotropic drugs. And then we also learned of multiple prescriptions, and starting with one and then another being added and another being added, change from facility to facility and maybe a new prescriber, and really some quite horrific stories. One young man who came out the other end amazingly and is now a young adult who's pursuing education. But when he tried within a group home to get an opportunity to meet with a psychiatrist or a prescriber just to review his prescriptions, he had privileges taken away from him for the simple act of raising a request really for medical treatment. And the response was, that's aberrant behavior, that's
Willful defiance.
Defiance, exactly. And so up the prescriptions, take away privileges of television or computer access, whatever. Just it sounds more like an incarceration situation than a caring home site that's helping someone. Now, obviously, resources are a huge problem in this, but one of my questions related to this ongoing work to better understand reporting and sharing of data, et cetera, one of the things that we learned in that hearing as well is that many of these prescribing physicians are receiving monetary rewards from the pharmaceutical companies based on their rate of prescriptions. Are you looking at that at all? To me, that it's unethical, and there should not be a monetary incentive for doctors who are prescribing psychotropic drugs to children in foster care who are really wards of the state or wards of those foster parents who may have no understanding of the medical treatment protocols and or access to real-time counseling services. But to me, if we're in a system where the more prescriptions, the more financial interest for that prescribing physician, that defies any ethics code around, and it should be made illegal and a subject of scrutiny, at least for those youth that are within care systems under the control and supervision of the state of California. Do you have any thoughts on that?
Yeah, absolutely. We have thoughts on that. We very much appreciated the opportunity to participate in the hearing that you referred to, and very compelling testimony by a lot of youth, including the one that you specifically referred to. As the Department of Social Services, we don't have oversight over prescribing physicians. However, as I also mentioned, we are a signatory on the data sharing agreement with the medical board that will allow them to pursue those very investigations. And earlier this week, we assured the medical board of our full, complete cooperation in the investigation for every instance that they find of something, as you've described. We have a larger concern about the health and well-being of the kids and want to be a partner with them in the investigation so that we can assure that our kids are being treated appropriately.
Right. Well, thank you. And I should have perhaps prefaced it. I do understand that with proper oversight and proper judicial oversight, these prescriptions in some cases inure to not only the benefit of the young person, but to the safety of other young people and to the safety of care providers. So that's the broader context of this. But when it becomes a tool to supplant more direct engagement in developing a plan with a young person, the ones we heard that had success stories, it was somebody paid attention to them, listened to what they had to say, and demonstrated some care for that person as an individual. And again, our system is short on those resources, but we're just kicking the can down the road when there's only a medication approach to working with kids who, as we heard, come from very tough backgrounds, that it's no surprise that they're struggling given some of the horror stories that they've emerged from. So again, I know it's a priority for, I think I speak for everyone here in our subcommittee and more broadly in the legislature. So we look forward to working with you. There's got to be a way that we can better manage the reliance on the psychotropic drug administration.
I would add to that before you respond. The department responded to a letter penned by Senators De Leon, Monning, Bell, McGuire, and Mitchell with some specific responses. We just got the response yesterday. I'll share my copy with you, Senator Stone, where we talk about some of these very issues, and just to say that, you know, not only that joint hearing, but there are a number of pieces of legislation going through the process, one of which I'm carrying to continue to look at making sure that it's not just a matter of prescribing drugs, but there's a true mental health kind of plan and assessment provided each of these kids. One quick follow-up, as you talked about all those who signed on to these various agreements, you know, where's the provider community in that? When you consider the number of, it's like someone trying to call me. I've touched all the phones. I can't, nothing's ringing. What about the group homes as the providers that appear to have a disproportionate higher rate of foster youth who are prescribed psychotropic drugs? You know, how is that folded into this kind of this oversight process? Sure. You mentioned the medical board, the two state departments. How is that then tracked and monitored as well?
Sure. So I'm going to come back to that because I think it's a little complicated, but as Senator Monning alluded to, I think he's exactly right. The issue of psychotropics is not one that's addressed in isolation of everything that's going on around it. In the two previous issues, we heard a lot about the availability of alternative mental health treatment services and those kinds of things. So making available alternatives to medication is one component of it. You've also described the caring, nurturing environment. I think the director will talk about that in the context of CCR and when we get to that topic, the continuum of care reform, sorry. So we completely agree and appreciate that. Specifically in the context of group homes, I think we'd all also agree there are instances where the use of psychotropic medication is completely appropriate and it's a physician's diagnosis of that. But having said that, I think when you ask specifically about group homes, it's both troubling that they have higher rates of use, but also somewhat intellectually predictable, if you will, in that the youth who tend to go to a higher end group home have experienced more trauma and have other issues. So I think when we talk about higher use in group homes, it may be appropriate, it may not be appropriate. There are group homes that specialize in kids with those kinds of needs. So it becomes a very complicated discussion. That said, I finally remembered the last thing I wanted to add on the data work group, work product. The other thing that that group has done is reach consensus over both the use on an ongoing basis, the production of information on 3 HEDIS measures. These are outcomes used in the health community, and as well as 6 other, we call them, I don't want to call them outcome measures, but measures of quality and use, looking at the rates of use, for example, the amount of time that elapses between a prescription and a metabolic monitoring event to see what impact that's having on the youth. So between the 3 HEDIS measures and the 6 other measures, they've also looked forward to our ongoing monitoring of the use of these. And I think given your question, that's important that I add that in.
Thank you.
Senator Stone.
Thank you for your presentation. I appreciate it. I wasn't here when they were having the hearings on some of these more troubling instances where homes were using drugs as chemical restraints or punishments, and that's not something that certainly I condone, or I'm sure my colleagues condone, and we certainly want to weed those bad providers out. And I see the utilization of psychotropic drugs as a tool, as one tool to helping these kids. Now, there are some that chronically are going to be on psychotropic medications in all likelihood for the rest of their lives, those that suffer from diseases like schizophrenia or bipolar diseases. But in reading some of the statistics, children in foster care are more likely to be prescribed psychotropic drugs as they grow older. 2, the likelihood that a child will be prescribed multiple psychotropic drugs increases with age. 3, children in the most restrictive placement settings are more likely to receive psychotropic drugs or multiple medications. Just a couple of questions. One, psychotropic drug has many different types of drugs in its classification. I think it would be useful to know, how many of these are antidepressants, how many of these are antipsychotics, how many of these are anti-anxiety. It could give you some clues as to which ones are being utilized for appropriate reasons and not appropriate reasons. Question I have is why do you think that the utilization of psychotropics have increased so much in foster youth? And we see that in the more restrictive settings, that there's more of those drugs being utilized. Are we not giving appropriate alternative therapy to those in restrictive settings that may be a more stressful setting, obviously, for these youthful people, and trying to help them cope with their issues?
So as I mentioned a minute ago, in the more restrictive settings, if you will, those tend to be places where children with higher needs tend to be placed. I think the expert panel, I know the expert panel has struggled with the question of what is the right level of use, because it's really an individualized determination based on the need of the child. We are working to increase access to specialty mental health services and other things that we've been talking to previously. We think that's a potentially mitigating factor here. I don't know that we have a clean idea of what the baseline is that we ought to be comparing ourselves to for use. So I'm struggling a little bit to give you an answer for why it might be increasing or not. We actually saw a decrease a number of years ago when the Department of Healthcare Services for Medi-Cal implemented a TAR policy for children under 5, we actually saw a dramatic reduction. As described here on page 14, in October last year, October 1, implemented a TAR policy, Medi-Cal-wide, not just for foster youth, requiring a TAR for these prescriptions for any youth 17 and under. We're still collecting information on what impact that has on prescribing rates. We think that secondary review, given the importance and the impact of these medications on youth can be, as we heard in earlier hearings, is a valid one that we should see what the impact of that policy is. Again, the TAR policy is, one tool in our toolkit here, educating the courts, educating social workers, educating youth and their caregivers, the availability of alternatives. These are all parts of the solution to the issue.
And what about the breakdown of the type of psychotropic drug that's being utilized? Can we get that information broken down in a little more detail?
I think we're able to produce it, if I'm not mistaken, off the top of my head. I think of the psychotropics prescribed to foster youth, about 60% of them are antipsychotics.
Really?
Yeah.
I would have suspected antidepressants to be the majority.
Well, and we do have those numbers. We can share those with you. And that have been looking at the different kinds of classes of medications. So I don't have the numbers off the top of my head either, but we have done that breakout for the antidepressants versus antipsychotics,
Yeah.
et cetera.
I think
If
that
you
could be
could share that with committee staff so we could all get it, that'd be helpful.
Yes, ma'am.
Thank you so much.
Could I just?
Yeah, Senator Monty, of course.
You've responded to this already, but again, in looking at the matrix of decision-making points from treating physician to the courts to care facilities, et cetera, if the foster youth or a Medi-Cal recipient youth, if the state of California is paying the cost of the medical treatment, has there been any thought to not allowing a physician to participate in the program if they're simultaneously receiving economic incentives for prescribing?
My name's Dr. Lynette Scott. I'm with the Department of Healthcare Services as the Chief Medical Information Officer. And as Pete said, we are working with the medical board and DSS around those different components. I think one of the things to keep in mind in general, though, is that there are a variety of ways in which the health system works in terms of providing different kinds of grants as well as funding. So sometimes there's funding that comes from the private industry around training, education. And so I think it's important to clarify what aspects are perhaps CME, which is continuing medical education that comes to providers, which has to have freedom from bias and not be, specific to selling a product, versus something that is actually potentially an issue, as you've described, and that's where we'll be working with the medical board in terms of taking a look at that.
Well, thank you, and again, I appreciate the sensitivity to the issue, and I do understand in the broader medical profession, there's continuing education, education matters, and trainers at those or speakers often receive compensation for their travel and for teaching, and they have to reveal if they're receiving compensation from a particular pharmaceutical company, for example. I think that should also be included in the mix, but I think the concern that we've learned of is a direct correlation between prescribing and receiving economic consideration based on the rate of prescribing, which to me should not be part of what the state of California is participating in.
And we do not support that activity. But again, there were a number of articles and headlines that came out last year around this, especially as at the federal level, they released some more data sets around what is being spent in the industry and who that's being provided to. And I'm not sure that everything was understood as well as it might be as that came out. So there's a lot of subtlety to it in terms of breaking down the different kinds of payments that occur for what purposes, such as education and research, as opposed to something that would be truly an incentive that is an ethical problem.
Thank you.
Thank you very much. Again, I would just say that we recognize that critical initial steps have been taken to tackle this issue. We appreciate that. And finalizing the data sharing agreements, systematically reviewing the data and identifying courses of action based on this data will really help ensure that foster kids are not inappropriately medicated. And these are issues that clearly the legislature is going to continue to want to partner with you on and legislate around. So it's an area of deep concern. With that, slow my roll. Public comment, please, on oversight issue we're discussing, psychotropic medications.